I'd like to introduce Dr. Kshitij Kapoor, who will be doing our grand rounds for today. Dr. Kapoor completed his medical school training in India, and then he came here to Houston and got his master's degree in public health with a major in health promotion and behavioral science here at the University of Texas at Houston. Subsequently, he joined our general psychiatry residency program, and he is currently a second-year child psychiatry fellow here at the University of Texas at Houston. And he is going to be talking today about one of the new diagnoses in DSM V, which is disruptive mood dysregulation disorder. So I'd like to welcome Dr. Kapoor.
Thank you, Dr. Santos. So one of the reasons I chose this topic, disruptive dysregulation mood disorder, is because I also didn't know about that topic before that much, because it's a new diagnosis. I thought it's a really good topic to learn about it. And once I learned about it, I thought maybe it's a good topic to present at the grand rounds, because I thought it could be very educational for everybody. So before I start, I just want to make some disclosure. It's Dr. Santos. She received a research support grant from CureMart. And this is my disclosure that me and my family member have no role in DSM V task force and have not participated in any discussion for this new diagnosis of disruptive dysregulation mood disorder. If you have any doubt about this diagnosis, please go to dsm5.org and leave your query. This presentation is purely for educational purposes. So before I start, so there's a very important thing in mental health is, like, road to the mental health begins with an accurate diagnosis. It's a really important thing to understand about. I think it's true for all the specialties, but it's very, very important for the mental health that we need to have an accurate diagnosis. This is the kind of basis for my presentation. And can anybody tell me who said these words? Any student, any resident? Make a guess. It's not a test. Just make a guess. Einstein. Not all the words of wisdom come from Albert Einstein. There are some other people also who have wisdoms. Okay. Napoleon? That's a good guess. I like it. All right. So, it's American Psychiatric Association. So, today the learning objectives of my presentation is like how we felt the need for DMDD and how the birth of DMDD took place. And before that, defining DMDD, what's the concept of irritability, because it plays a big role in defining DMDD. I will be using DMDD for disruptive mood dysregulation disorder. I just want to clarify that. And how we manage this DMDD and what's the take-home message. So let's see how the birth of DMDD took place. So when we look back in mid-90s and early part of 2000, there was an exponential increase of bipolar discharge diagnosis. The studies were showing that if you look in the inpatient discharge diagnosis in between 1994 and 2004, like in 2004, like in almost 8 years, there was an increase from 10% to 34% in children and in 10% to 49% in adolescents. And if you look at the graph, the yellow part is the bipolar part. And if you can see that there's a lot of increase in bipolar diagnosis. And this thing happened in children, this thing happened in adolescents. And just to simplify the graph, you can see that in 1996, it was 1.3, and in 2004, it was 7.3. So it's five-fold increase in the diagnosis of bipolar diagnosis. And it was happening in the inpatient. And the same trend was noticed in the outpatient setting too. It was 40-fold increase in the diagnosis of bipolar diagnosis. You know, one time I was interviewing a kid, and I said, what do you think you, like I was just asking him a couple of questions. The kid said, I think I have a bipolar. I said, why you have bipolar? Because it's cool to have that diagnosis, you know. So, but the thing is, to have bipolar means that you might have a lot of functional impairment. That is very important to understand. So, so this was the trend going on. There was a 40-fold increase in the office setting also. And so there must be some reason why there was an increase of bipolar disorder. So there are some thoughts, the researchers are thinking why there's an increase. So some thought maybe the youth bipolar was previously previously underdiagnosed, which is a possibility. But some researchers felt that the way the diagnostic criteria was applied, leading to misdiagnosis, which could be a really good possibility. And the third thing which we commonly see, that sometimes just to get the mental health services, to put the diagnosis, to get better services, to put the diagnosis of bipolar disorder instead of mood disorder or something else. So before going further, let's see what bipolar disorder means. So we know that there are in most of the slides, I'm talking about DSM-4 diagnosis, because this thing was happening when DSM-4 was there, but DSM-5 was not there. So this is according to DSM-4 diagnosis there. You know that there's A symptoms and B symptoms. And the A symptoms, I will read the A symptoms because it's very important. They said it's a distinct period of abnormally, persistently elevated, expensive or irritable mood. So they are talking about irritable mood here, but the thing is, their core definition of bipolar comprises of episodic irritability. They're not talking about chronic irritability. When we say about episodic irritability, it means that you had an episode of mania or you have an episode for 5 to 7 days when you were irritable. It's not that you are irritable all the time. So they are talking about episodic irritability. But some researchers felt that mania in youth may present as non-episodic, persistent, chronic, or severe irritability, and which was kind of making them to make more diagnosis of bipolar. So there was a debate. People were thinking, there's a bipolar. I think this is the right diagnosis, or the chronic irritability represent the developmental stage of future bipolar. But some people said, no, it's wrong. There's something else going on. There's something which is not bipolar. There's something which may not come before bipolar, but it's something very different from bipolar. So, but before going on to those things, I would like to discuss a little bit of irritability. So I just mentioned that there's two types of irritability. One is episodic and chronic irritability. And irritability is defined as a low threshold to anger in response to frustration. It is one of the most common symptoms of pediatric population. It's a part of the clinical presentation of several disorders, especially in the pediatric population. And DSM-4 provides no definition for irritability, despite having inclusion in at least 6 diagnoses. And the 6 diagnoses mean there's so many opposition-defined disorder, there's conduct disorder. All these diagnoses say irritability, but nobody defines it. And no category of DSM-4 actually captures the impairing non-episodic irritability. Nobody's talking about chronic irritability. And so the people tried to find out what this chronic irritability is, and they found that the construct of episodic and chronic irritability are separable. They're actually stable. They never overlap with each other. And what they found in the longitudinal studies were that episodic irritability sometimes leads to GAD, like maybe sometimes phobia or mania in late adolescence, but the chronic irritability never leads to bipolar. It leads to maybe major depression. It may lead to disruptive disorders, but no mania, no bipolar. So, and also they found that in emotional dysregulation, there's so many disorders, they overlap with each other. The anxiety, depression, aggressive behavior, eating pathology. So based on all these facts, I found this picture on the internet, and I felt that it's really interesting picture. If you see this picture, if you take one side as a bipolar and the horseman as a researcher or a scientist, so they're actually thinking right now whether there's a bridge to bipolar or whether there's no bridge actually, or is something different, is something separate from bipolar. So somebody needs to take a lead, and in 2003, Dr. Ellen Leibenloft, she took the lead. She's a very well-known researcher in National Institute of Mental Health Sciences, and she thought that I think that we need to do something. She proposed something like this, like if the severe non-episodic irritability, like chronic irritability, is a developmental presentation of mania, if yes, then it should be expected to develop into bipolar when we do the longitudinal studies. It should have a family history of bipolar, just like other bipolar history. In the bipolar disorder have a strong familial background, so we should expect the same thing with this chronic irritability traits and the new entity which have a chronic irritability. And it should have a similar pathophysiological abnormalities too. So based on these three things, she actually defined a syndrome called severe mood dysregulation. So there was some inclusion criteria and exclusion criteria. I will go through real quick about the inclusion criteria. She said that the age is between 7 and 17. Patient needs to have abnormal mood present at least half of the days, most days, and of sufficient severity to be noticeable by people in child's environment. It needs to have hyperarousal symptoms, and compared to peers, the child exhibits marked increased reactivity to negative emotional stimuli, which can manifest as verbally or behaviorally. And the symptoms must be present for 12 months, and you should not have symptom-free periods more than 2 months. And it should have, the symptoms are severely impaired in at least one setting, home, school, or with peers. And it also has some exclusion criteria, and one of the soft exclusions, you can see that it IQ less than 17. If you have to differentiate something from bipolar, the patient should not be manic, should not have a manic episode. So we are talking about an entity here which is called SMD, severe mood dysregulation, and we want to see how it's different from bipolar disorder. So that's the goal of Dr. Leibenloff. She in the start, she doesn't say that anything like, okay, she's not saying anything right now like, okay, they are different. They just want to test it and see whether they're actually different or not. So what she did on the basis of this inclusion and exclusion criteria, she recruited 146 patients, like 145 kids, who actually had SMD according to this inclusion and exclusion criteria. And the way they did it, but they did the scale, KSADS, and also this scale was administered by a doctoral level clinician. So just to decrease the error as much as possible in recruiting the patient. And what they found that the mean age of the study entry was 11.7 years. And what the other thing they found that the Children Global Assessment Scale was 45.8 as compared to 46.5 for 107, which they also recruited for bipolar disorder. So I said to you that they are recruiting two kind of patients, one who have bipolar and one who has SMD. And what they found that when we look at the scales look similar, which means that the severe mood dysregulation are actually equally impaired as just like with the bipolar disorder. So the impairment level is kind of the same in bipolar disorder and SMD. And also, very interestingly, they found that the 60% of the patients which they recruited for SMD had a diagnosis of bipolar diagnosis. So you can see that the 60% of the patients which they recruited, they already had a bipolar diagnosis, but they actually, according to the research, they qualify for SMD, not for bipolar. And they also showed that almost 85% also met lifetime opposition-defined disorder, 86% met ADHD, 58% met lifetime anxiety disorder, and 16% also met lifetime major depressive disorder. But the thing about this major depressive disorder is if the irritability is due to major depression, those patients were excluded. If the irritability is not due to major depression, only then they're included in this study, because irritability is also a component of major depression in kids. So Dr. Leibenloff actually suggested there are 3 ways we can test this, because now it's a scientific world. We need to test it. We need to do some field trials. We need to do some experiment, whether this new thing, SMD, actually is different from bipolar, or is just one of the developmental manifestation of bipolar. There are 3 ways which we can do. One is longitudinal studies. One is the family history, because bipolar patients have a strong family history. And one is pathophysiology. So in terms of longitudinal studies, So they did some studies. There are two or three studies they did. And one of the studies they did was they followed those patients, SMD and bipolar patients, for almost more than 2 years. And what they found that only 1% of SMD actually got into mania. And more than 60% of the patients got manic episode from the bipolar group. So, which means that SMD, like when we follow for 2 years, there's no mania. But if you follow bipolar patients for 2 years, there is more than 60% people are getting mania. So this is a graph. If you maybe it will help you to understand a little bit better. If you see this one is on the purple one is bipolar and this is the SMD, and you can see there's just 1% people have mania. And almost more than 60% people develop mania. And we know that in bipolar we do get mania. So right, if it's a right diagnosis, people will get mania. But in SMD, nobody, like almost just 1% got mania. So there is something happening. This entity may be different from bipolar because it's not getting into manic phase. Like people not getting manic because that is actually one of the core feature of diagnosis of bipolar, to have manic or hypomanic episodes. So some other people also did some longitudinal studies, and one of the investigator Rotman et al. They found that there are 7 times more likely to meet criteria for unipolar depression disorder at a mean age of 18.3 years. So they found the people who qualify for SMD, they have 7 times more likely to have unipolar depression, not the bipolar depression. That one of the longitudinal studies showed. And another study again showed the same thing, that the chronic irritability in adolescent predicts major depression at age 33. So there are 3 studies which are actually pointing out that this SMD is not making the people manic. Like there's something else going on. It could be depression, it could be anxiety, but it's not mania. So this is one thing, this is one part. And the other part we were discussing about the family history. So what they did, like they started interviewing so they recruited patients for the study, but then they started interviewing the parents of the patients who actually recruited for the study. And they found that in bipolar group, as expected, it was 33%, but in SMD sample, it was just 2.7%, which is way less than bipolar. So it appears that these patients may not have family history, positive family history for bipolar. So it's just, it's all the experiment. They're just trying to figure out what's happening. They're just trying to see whether this condition is different from bipolar or not. And the 2 things have actually shown that. One is longitudinal studies, and one the family history, that there's something else going on. It could be different. It could be different. So let's see what happened next. So this is one of the graph, this is the table they did, and you can see, let me see. Yeah, this is 33, and if you go here, in SMD is 2.7. So before going to pathophysiology, how do we test the pathophysiology? Now in psychiatry, everybody is doing scanning. fMRI is one of the ways we can know what area of brain actually is involved when you're thinking, when you're playing. So that's how the fMRI is. But a little bit about fMRI before I went to the other experiment which they did to differentiate or to find what's the difference between SMD and the bipolar. So fMRI is an MRI. But what fMRI do is like they can actually pinpoint the parts of the brain when we are thinking, like, okay, if I'm smiling and I'm having a brain activity back in my brain. So, and the fMRI can capture that, which part of my brain was active when I was smiling, when I was angry, when I was aggressive. And the fundamental principle behind fMRI is the difference in blood oxygenation level. So they generate a brain map corresponding to the blood flow to active neurons. So this is the principle behind fMRI. And fMRI actually fMRI is one of the ways we can test the pathophysiology of mental disorders. And can anybody tell me who is the founder of fMRI? Any guesses? Have you heard about fMRI? Okay, good. And so this Dr. Ogawa is he was the one who actually invented fMRI, and that's how he looks. I always try to see how people look. So. And he's been actually, I've heard so many times that he will get one day Nobel Prize. He's been like this he had changed, with the fMRI, so many things have changed so immensely that there's a good possibility that one day he will get a Nobel Prize. And he already got a Japan Prize, which is equivalent to a Nobel Prize in '93. He's right now 80 years old, and Japanese are supposed to live very long, so hopefully he will get, and we will be able to see him getting the Nobel Prize. So coming back to where we were actually, so what they did with the fMRI. So there is one experiment they call facial emotional labeling. So what they do with that kind of experiment is like, there's a healthy control, there's a bipolar patient, they're an SMD, which the Dr. Leibenloff described. So, the healthy patient, they will look at the different faces. What they do, like they will show a smiling face, and the healthy patient will look at it and will say, okay, it's smiling. And then they will show another face, it's an angry face, and the healthy person will say, oh, it's angry. But what happened with the bipolar patients is, like in bipolar patients, they have a deficit of facial emotional labeling. If they see a neutral face, sometimes they feel that it's hostile, they're angry. So that kind of thing, we try to find out whether they have the same thing in SMD. So that kind of experiment they try to do with SMD also. And what they found was, yes, both groups have a deficit in facial emotional labeling, and they both experience more frustration in normal developing children. So yes, they both have the same deficit, but when they further went down, they found that the neural circuit is different. The activity brain is different. So the brain mechanism is actually different for SMD and bipolar. And what they found, as you can see in the graph, it's very easy actually. I'm not an expert on fMRI, but if you look at it, this is an amygdala activity, and you look at the healthy comparison, then go next ADHD, then you go next to bipolar, and then you go to SMD. If it's a simple graph. You see all the positive in bipolar, but when you go to SMD, it's negative. So which means that the amygdala activity is on the lower side as compared to when we see it in the bipolar. The bipolar, the amygdala activity is more, but in SMD, it's low. So there is a difference in brain mechanism between bipolar and SMD. And the same thing, surprisingly, one of the studies showed that if you look at the graph, they found the same thing in depressed children. So let's go back and see. This is SMD. This is the same amygdala activity, and you can see the downward thing, and the same thing you see in the depressed child. So you can so the SMD kind of corresponding depressed child, but it's not. And you can see the sample was not a high number, but the thing is, like, there are something. Even the pathophysiology part is also showing that it's a little bit. There's an entity which is different from bipolar and kind of be similar to depressed rather than being bipolar. So, so one thing, this is the one thing that we were doing in the research side, but there was also one article published in Wall Street Journal in 2012, and the DSM task force was actually going through this project, whether to get this diagnosis or not. So I will actually read these couple of interesting cases they enumerate actually. And they said that the decade of suffering of 11-year-old boy who, although diagnosed bipolar disorder at age 4, has never been successfully treated for his extreme explosive rages. They also mention another case, 12-year-old girl whose mom feels that it's like walking around him with an arm full of explosive. You hope that you don't trip. And they pointed out a really important thing, that it's actually like too many severely children, impaired children, are falling through the cracks. They suffer from a disorder that has not yet been defined. It's not bipolar, but it's something that's not defined. But they're getting a diagnosis of bipolar because we don't have any diagnosis. So this is one of the cases which I saw in clinic, and I thought I should just briefly I will go through this case. So this is Mr. A, who was first seen by a psychiatrist at age 7 for his temper problems at school and at home, and when the evaluation was done, he was diagnosed with mood disorder NOS, and then after a few months, he noticed to have increased outburst and also being very hyperactive, got the diagnosis of ADHD, started on stimulants, and the therapy was also started. But over the next 6 months, his irritability got worse and worse. He's still hyperactive, will throw tantrums, fight with his brother, fight with his peers. So stimulant dose were adjusted. He got a little bit better, but he still remained irritable all the time. And another next 6 got worse, increased aggression mostly in the evening, increased oppositional behavior also. Does not get much help from the additional stimulants at noon. Got diagnosed with intermittent explosive disorder, and then the clonidine was added. In the next 6 months, he started making suicidal statements like, I would get my mom's knife and kill myself. Got diagnosed with depression. We are not doing anything here right now. It's just that's how we got this case. And 3 months later, mother reported that threats of suicide made by patient because he was watching CSI and got an idea from there. It was more like getting attention rather than a suicidal thing. So Rembrandt was discontinued, but he was actually started back on clonidine. So in the next 6 months, mother reported that he's getting more aggressive at school. He hit a girl, got suspended. Patient remaining irritable most of the day, most of the time, poor frustration. He was diagnosed with bipolar disorder NOS at that time. And if you notice that in my history, there was not a clear episode of hypomania or mania anywhere described. But the patient still got a diagnosis of bipolar disorder NOS from the previous doctors. And he was continued on risperidone and stimulants. Mother reported some benefit with risperidone, decreased aggression and fear outburst. So when he was 11-year-old, the mother reported nocturnal aneurysm with risperidone, and then she said that when the patient was off medication, they didn't have the issue, so risperidone was discontinued and was started on Abilify, and still have stimulant and also clonidine actually. So this is the time when we saw the patient for the first time. At that time he was diagnosed with bipolar disorder NOS with ADHD, was on Abilify and stimulant. Patient still had issues with irritability and having episodes of rage at school. Mother was actually very fearful that the patient may get involved with law. Patient reported that he felt more aggressive with Abilify, and mother also felt the same. So we stopped the Abilify and continued with ADHD medication, clonidine. Patient started going to therapy which involved cognitive interventions, and actually patient started improving a lot, and this patient has a negative family history of bipolar disorder. So this is just a small example what we see in the clinic, and I'm pretty sure so many psychiatrists have felt that it doesn't seem to be bipolar. It doesn't have manic episode, but he's still carrying the diagnosis of bipolar, or maybe he sometimes gets a diagnosis of mood disorder NOS, because nobody was sure what was happening. Is there something else? It's something new, but there was nothing in DSM-4 actually to actually diagnose these kinds of kids. So they sometimes get into ODD diagnosis, sometimes they get the diagnosis of conduct disorder, sometimes they get mood disorder NOS. So they keep on revolving between these diagnoses, and many of the cases, as I mentioned previously, that they do get the diagnosis of bipolar. So definitely, there's a need to fill in the cracks. There's a need that we need to feel something which is not bipolar, which is something different, and which could have which has a different long-term prognosis. So, and one of the way, as I mentioned, is to get an accurate diagnosis. This is very, very important. Like for the mental health, we need to make an accurate diagnosis, but we can make only accurate diagnosis when we have the diagnosis. If we don't know about the diagnosis, then how we can make the diagnosis? So that was something, that was one of the motivating, I think, one of the motivating thing to go ahead with this diagnosis and make people aware of it. And also, when we say bipolar, it's not a cool thing to have bipolar. Bipolar means a lot of impairment, functional impairment. I hope so many residents have seen actually people who have bipolar. They can't function, and they're having those episodes, they can't function. They might be stable on medication. They might be able to, they might be able to walk when they're not having episodes. But when you are having episodes, it's so hard. It's functionally impaired. Like you can't do it, and that's why it's not cool to have bipolar diagnosis. And also, one of the reasons why we were actually thinking about other things is also because we also want to limit the unnecessary use of antipsychotic. If you interview 100 parents, actually, I think almost 99 parents would say that they don't want their kids to be on medication. And when they learn about antipsychotic, no, we don't want any. Like they may say yes for certain stimulants, maybe it says yes for antidepressant, but when they talk about antipsychotic, no, we don't want our kid to be an antipsychotic because it comes with the baggage. It has a lot of side effects. It has a lot of long-term side effects too. All right, this is one of the just want to summarize it. I mean, I already summarized it. So back on the things which we discussed, the longitudinal studies, the family history, and pathophysiology. The three things are coming up, that the SMD has a low familial trait. Number two, SMD on long run can have unipolar depression, but not bipolar. And SMD pathophysiology looks different from bipolar. So these are three simple things. It's not very big things, but simple things. They did it in a very scientific way to prove that this entity seems to be different from bipolar. But they're not the people who make the decision. The people who make the decision is DSM task force. So with all this research and everything comes the DSM task force. So if you remember my disclosure that I told you that I was not in DSM-5 task, so you can see that my name is not here. And neither Dr. Ellen Leibenlock, who actually did the investigation and everything. So because it would have been a conflict of interest. So DSM task force, they got all the research and everything they got. Now they're thinking, now they're doing things and debating themselves that whether we need to make this diagnosis or not. Because there is something, the research have shown that this is something different from bipolar. And we need to make some decision because, between DSM-4 and DSM-5, it's actually almost almost so many years. It takes so many years to get to DSM-5. I mean, I'm not sure. It's almost 10 years, I think, when we had the last revision, and then maybe even more. And then if we miss now, I don't know when we will get that diagnosis because we don't know when the DSM-6 was going to happen. Maybe many years before the DSM-6 can come. But so we need to take some decision, and I think the DSM-5 thought that it needs to be addressed, and this is something which comes under mood disorder, and that's what they made, and we need to address the chronic irritability. So that was the task of the DSM-5, and what they did that, according to, when we look back the previous diagnosis, so they exclude the hyperarousal symptom, which were actually included in SMD, because they just want to make sure that this is entirely different from bipolar. So they excluded the hyperarousal symptoms. They also exclude the preschoolers because and patients whose symptoms did not begin until adolescence. They exclude youth with even brief episodes of mania, so that there's no conflict with bipolar disorder. So this is the process which happened before the diagnosis got approved. I just got it from DSM V site, so I don't mean. So the process is like there's a review of scientific literature, there's a full discussion by work group members, there's a scientific review committee, there's a clinical and public health committee, and finally it's approved by American Psychiatric Association Board of Trustees. So it's a long process. It's a very, very long process to get the diagnosis. And if it's easy to, criticize anything, but I think if we need to appreciate that there's so much hard work has gone through to get this diagnosis. Like Dr. Labenloft started her research in 2003 about this thing, SMD. So it almost 12 years actually, almost 9 years before we got to this point that now we understand that this thing is different from bipolar. So it took 9 years. So it took a long time to understand, because they just want to make sure, they keep repeating the experiment, they keep doing the thing, they want to make sure that it's actually different. Because it will be going, because they want to present it to DSM-5. And finally it got approved, and so this is how the process is, like chronic irritability. One time actually they started calling this, when they were in the discussion thing, they started calling it temper dysregulation dysphoria. So before giving the name out, disruptive dysregulation, the name was temper dysregulation, and there was a lot of hue and cry and from the parents' side, because they thought that we are actually kind of, I would say, temper tantrums, because it goes with temper tantrums. They was thinking that, now you're making the disease out of temper tantrums. So they did. So they decided to change the name because it has nothing to do with temper tantrums. So they decided to change the name to disruptive dysregulation mood disorder. So we'll now we have reached a point when we can actually define DMDD. So yeah, that's how sometimes the DMDD kids look. It's true. If you so the DSM-5, according to DSM-5 criteria, I will actually go through everything because I just want to make sure you understand what DMDD is, and because that's the purpose of my grand rounds today, that you know about DMDD and you should know it's different from bipolar disorder. So the DMDD, according to DSM-5, it's a severe recurrent temper outburst manifested verbally, could be a verbal rage, or behaviorally, like physical aggression towards people, that are grossly out of proportion in intensity or duration to the situation or provocation. The temper outbursts are inconsistent with developmental level. The temper outbursts occur on an average 3 or more times per week. The mood between temper outbursts is persistently irritable or angry most of the day, nearly every day, and is observable by others, like parents, teachers, and peers. This is very important. The mood between temper outbursts. Kids do get temper outbursts, but when the mood between the temper outburst is persistently irritable, then it is DMDD. This is a very important thing to understand. If you understand this thing, you will be able to differentiate DMDD from opposition defined disorder. You will be able to differentiate between conduct. So you will be able to differentiate with everything if you understand this simple basic concept that the mood between the temper outburst is persistently irritable. And that is called chronic irritability. And criteria A to D should be present for 12 or more months, and throughout the time the individual has not had a period lasting 3 or more consecutive months without all the symptoms in criteria A to D. Criteria A and D are present in at least 2 of the 3 settings, home, school, and peers, and are severe at least in one of the settings. And it should not be made before age 6 and after age 18. And the age of onset should not be before 10 years. And DMDD, like the DSM also excluded few things it's very important to know that there never have been a distinct period lasting more than 1 day during which the full symptom criteria except duration for a manic or hypomanic episode have been met. So it should not be there. It should not be there even for 1 day. And but I was reading a couple of other articles. They said that it also means that if you have there's one thing called activation and one thing called mania. So sometimes the kids will tell you that, okay, I didn't sleep all night. I was very excited, and I had a lot of energy. And you ask the other question, what was the reason? Oh, I have a birthday party tomorrow. I was about to go to vacation. So if there's if you find these kind of things, this is not manic episode, and they're not functionally impaired. When you have manic episode, one important thing bipolar is that you are also functionally impaired. Functional impairment is important to make a diagnosis of bipolar disorder. People say that I think I'm depressed, but I'm able to do everything. But this is but you don't qualify for a diagnosis if you're not. If you're functionally everything is all right, then and that's the reason you're not going to a doctor also. But you feel that you're sad, but you're able to do everything. You're not functionally impaired, but functional impairment is important to make a diagnosis. And also the behavior do not occur exclusively during an episode of major depressive disorder. So I told you before also, if the irritability component is due to major depression, then it's major depression. It's not DMDD. But if the irritability, irritability is not due to major depression, so the major depression DMDD can have a comorbid major depression. But if the irritability is due to major depression, then it's major depression. It's not DMDD. I hope I make this thing clear. Okay, let me repeat it. I think I a little bit. Okay, let's see one patient who comes to you, and usually in children, sometimes the depression sometimes appear as irritability. So when we take the history, and we feel that patient is very irritable, but at the same time he also tells you some of the major symptoms of major depression, like sadness, losing interest. So you think that this irritability is a part of major depression. It's not DMDD, because you can clearly see major symptoms of depression along with irritability. So when you see that kind of irritability with these kind of symptoms of major depression, it's not DMDD. It is major depression. And they also exclude the autistic spectrum disorder, PTSD, separation anxiety, and persistent depressive disorder. And that's a very important statement which they make. Those cannot coexist with oppositional defiant disorder, intermittent explosive disorder, or bipolar disorder, although it can exist with other, including major depressive disorder, which I just mentioned, ADHD, conduct disorder, substance abuse disorder, and individuals whose symptoms meet criteria for both disruptive dysregulation, oppositional defiant disorder, a diagnosis of disruptive should be given. I will come back to this point also, why we need to give DMDD diagnosis rather than in a patient of ODD. And if an individual has ever experienced a manic or hypomanic episode, the diagnosis of DMDD should never be assigned. And as with other conditions, it should not be attributable to physiological effects of substance or any other medical or neurological condition. This is actually a very important thing to remember, that to make a psychiatric diagnosis, we need to rule out this thing: the substance abuse, the medical thing, and the neurological thing. Sometimes we just, in a flow of things, sometimes we forget to give attention to these things, but these things are very important. So this is a really just to simplify how we diagnose the DMDD. So we are talking about irritability. We are talking about episodic irritability and chronic irritability. So the chronic irritability has two components. I just mentioned also. One component is verbal or temper outburst. Like it can come as temper outburst, which could be verbal, it could be physical. But the second component of chronic irritability is like in between the temper outburst, the mood is irritable. Like even in between, like okay, I just had a rage attack, and I calmed down. But after the rage attack, I'm still irritable. I'm still grumpy. Like it's not that it's not going away. And then again I got a rage attack. So in between the episode, you are still irritable, and that is what is chronic irritability is, and that what actually kind of differentiate it actually from bipolar disorder, because it's not episodic, it's chronic irritability. And And that's how you come down and you see that it's DMDD, not bipolar. So now you can see that, if you come back to the same picture, now the scientists have actually, the researchers are thinking that maybe there's no bridge. There was no bridge actually. We were thinking there might be a bridge, there will be a developmental something going on, which manifestation of bipolar. But now with all these studies, with this diagnosis, so things can change in future, I don't know, but for now what it appears that there is no bridge between, so bipolar disorder and this DMDD is different. And they found the lifetime prevalence for 3.3% in the DMDD. And I will not go through the DMDD and bipolar differences because now we know that it's different, and I've explained a few times. But people always have questions how we differentiate DMDD and ODD, because even when Dr. Leibenloff did the study, she found almost 85% also qualifies for ODD. ODD means opposition defined disorder. So first thing in DSM, if you look into DSM V, the DMDD comes under the mood disorder, and the ODD comes under disruptive disorder. And so these two things are one of the major difference between DMDD and ODD. And I told you one important thing, that when we diagnose DMDD, it has a chronic irritability. It's all chronically irritable, even between the rage attacks. And this thing is much more common in DMDD than ODD. And extreme aggression is sometimes more common in DMDD than ODD. And and ODD, everybody knows that it's a pattern of defiant and resistive behavior towards authority figure, which may or may not be there. So, and the DSM-5 said that because due to the high degree of overlap between ODD and DMDD, we should get the diagnosis of DMDD instead of ODD. And one of the rationale behind this, that they feel that it's the most severe disorder. It needs to be addressed. DMDD needs to be addressed, because we know that DMDD, with the research, that it may turn out into unipolar depression, anxiety. So it needs to be addressed, and they should have more access to services. The same thing, and sometimes the people ask about DMDD and conduct disorder. The same thing. It's under mood disorder. It's a disruptive disorder. And in conduct disorder, there's a lack of empathy, which is sometimes not a diagnostic feature of DMDD. Serious violation of rules, which may or may not be there in DMDD. So how we treat this? So it's a new diagnosis. If you go to the PubMed and you just type disruptive mood dysregulation disorder, only 40 studies come up. Like I just checked it yesterday evening. Actually, it's just 40 studies have done some research on DMDD. So there's a lot of research needed to be done in this field, and I think this is it's a really upcoming one of the upcoming diagnosis where the new researchers or new people who are coming out of the psychiatry, like doing a residence in fellowship, they can actually involve in this kind of research because it has a lot of potential. But some success had been met on the lines of treatment opposition defined disorder. So the only placebo-controlled trial was done in SMD with lithium, and there was no benefit of lithium over placebo. And there was an open-label trial with risperidone, and which showed that there was significant reduction in irritability score. And then there was a cognitive intervention where they actually have an improvement in Child Global Assessment Scale. So it kind of showed that maybe these kind of behavioral cognitive interventions can actually help these patients a lot. And on the basis of longitudinal studies, that they eventually get depression. So there's a trial right now going on at National Institute of Mental Health Science. It's actually with the SSRI, because on that principle they're actually doing SSRI and ADHD, to treat the aggression and ADHD symptom. It's actually they're comparing a stimulant plus citalopram to a stimulant plus placebo. So they just want to see how this SSRI make a difference. And this one is actually still going on. So I'm actually very excited about this research, and I want to see how these results come up, because if it gets successful, one thing is citalopram, it's not an antipsychotic. One other thing is like it's not very expensive for the patients to buy. So what the future is, as with the other mental disorders, we really need to find some clinical and biological markers that distinguish DMDD from healthy individuals and from other psychiatric disorders. And also, discovering more about the pathophysiology would be the second goal in diagnosis treatment, in guiding the diagnosis and treatment. So take-home message, DMDD is a new diagnosis which tries to fill in the cracks. The longitudinal studies have found that DMDD may present as depression and anxiety, but not bipolar disorder. With the knowledge of this diagnosis, hopefully the unnecessary use of antipsychotics can be avoided. And one more thing which sometimes we see is how do we build this? It's not very important, but I thought it's because it's a new diagnosis, and and when I actually typed in all scripts, I typed DMDD, nothing comes up. So this is the code for now till September 30, 2014, 296.99, which comes under other specified episodic mood disorder. And once the ICD-10, it's actually 534.8, other persistent mood disorders. And that's it. Thank you so much for your patience. I would like to invite Dr. Santos to say a few words.
I want to thank Dr. Kapoor for giving such a nice overview of really a decade of important work. It's been kind of a seesaw, because at first we didn't think bipolar disorder could exist in kids and adolescents at all. And then once we realized that really this disorder probably does often start in children and in adolescents, suddenly everybody who had a temper tantrum now had bipolar disorder. But that didn't really help us with our treatments. So over the decade, we kind of learned that there seems to be this subgroup of kids with this really horrible irritability. And I don't know if any of you have seen some of those kids. If you've rotated through 1E or 1D, you might have seen some of them. But the level of irritability is really intense and very difficult. And the families just always feel like they're walking on eggshells, like they can't say anything right. I was talking to a kid the other day after his successful treatment, and he was doing better. And he said, I just felt like everybody was always yelling at me all the time. And now I don't feel that way. And the family also had felt like, again, no matter what they said, he was upset about it. So then we took a decade of research, and we went from severe mood dysregulation disorder to temper dysregulation disorder to what we now have as DMDD. And the hope is that we can find some better treatments for this. It does look like this group of kids grows up more to be in the depressed and maybe even anxious realm, which might suggest the antidepressant route. And yet I know sometimes I get those kids that have some relative with bipolar disorder. We're always scared to use the antidepressants if they've got a bipolar history because we don't want to switch them to mania. So it can get very, very complicated when you think about the medication. And of course, the psychotherapy is really important, but we just need a lot more studies to figure out what the best treatment is for these kids. So that's all I have. Thank you to Dr. Kapoor, and I'll let him take any questions you have.
So, if you have any questions, you're more than welcome, but I told you everything that I know, but I will try my best. Right, yes.
So are there longer-term studies about development of bipolar in adulthood, since the usual time limit is in the 20s rather than in childhood and adolescence?
I'm sorry, your voice.
Are there any longer-term studies since the development of mania and bipolar is usually in adulthood rather than childhood? This might be a prodrome for bipolar developing later since some kids.
I mean, I'm not aware of that study, but
I think the evidence is becoming pretty clear that DMDD is not a prodrome to bipolar disorder. And I think if you study bipolar disorder, there is evidence that a lot of times it starts earlier than it gets diagnosed. And so I think Dr. Suarez could talk more about that. But usually if you talk to adults at their first diagnosis of bipolar disorder, they can talk about symptoms that they've had since childhood. But again, it tends to be more the episodic and not so much the chronic, really intense irritability.
But when I was actually reviewing the bipolar, the studies have shown that 50% of the bipolar disorder usually start in late adolescence. So, yeah, I mean, bipolar do start early, more than 50% of the cases. Okay, anything, any other questions? You mean, your students, any questions? I hope everybody learned something new, because that was my goal for my grand rounds. And thank you very much for coming.